Hey, thanks everybody. Really appreciate you joining us for Georgia MemoryNet Insights today. You are in for a treat. Our speaker is Dr. Gabriela Cohen. She is an associate professor at Emory University in the School of Medicine, Department of Medicine, Division of Geriatrics and Gerontology. She brings to the table decades of experience in working in cognitive assessment, and she is one of our leads at our Grady Memory Assessment Clinic. And today just really points out that Georgia MemoryNet is for all Georgians, and talking about making an early and accurate diagnosis accessible for all people that we serve. And so I'm really glad to have you here, Dr. Cohen, and I'm going to turn it over to you.
Thank you so much for the invitation. Welcome everyone to this lecture. I have nothing to disclose, and I'm going to go through these slides that would help you to get accredited for attending the lecture. And again, nothing to disclose. So, and here the instructions on how to get accredited for attending this and how to get CME, okay? So the idea today is to review a little bit unique features of risk factors for dementia and cognitive disorders in Latino population, the challenges that we face with we perform and we interpret cognitive assessment testing in patients who are not native English speaking. And I like to describe a little bit which cognitive battery we do in Spanish, and we're going to go through cases so you could see how we do it and how we make a diagnosis. Good. And I think Dr. Johnson will have the chat open. If we have questions or comments, that would be great. We'll try to do this as interactive as I can. I think I will say this because my first language is Spanish and not English. I'm from Argentina, and before joining Emory, I worked in an academic memory center in Buenos Aires for over 17 years. In that setting, I did cognitive assessment, memory disorders, and everything was in Spanish. And that's why when I moved to Emory, I observed that there is a large population of Latinos. And I kind of used my previous experience to try to adapt what we do in GMN to patients whose in Spanish is their native language. So this is interesting, and this is really from Atlanta. And the Hispanic population is growing. And I got this just a screenshot from different news and different papers. And it's really saying that we expected that the Latino population in Atlanta and the Metro Atlanta is expected to near double by 2050. So there will be a growth in this Latino population from currently 12% to 21%. So I think we're going to be facing more patients who present with memory disorders, who speak Spanish as a native language. So I think this could be useful in that.
Perfect.
Oh, I think someone has the mic on. Good, thank you. So what are the unique features in Latino populations living with dementia compared to non-Latino populations? So we see an increased prevalence of hypertension, diabetes, stroke, obesity, smoking, and cardiovascular disease. And all these vascular risk factors really increase the risk of not only Alzheimer's disease, but also of dementia. We see higher numbers of misdiagnosis and higher number of late diagnoses. And it seems that educational and socioeconomic factors are also well understood reasons for this disparity. So there is a genetic component, but there is definitely an environmental component related to the increased vascular risk factors and sometimes difficult to access the medical system. So this is from the Alzheimer's Association. I thought it would be interesting to place this slide saying that there is definitely there is a growing population of Latinos being diagnosed with dementia, that Hispanics are 1.5 times more likely than white non-Hispanic to have dementia, and that 1/3 of Hispanic Americans report that they have experienced some kind of discrimination when seeking healthcare, and almost 85% of the patients in this survey, they thought that having access to a dementia care provider will definitely improve their experience. So the Alzheimer's Association is looking into these too. So I think it's interesting for us at Georgia MemoryNet to try to see how we're going to tackle this problem. So why is it important to diagnose dementia early? And I always put these slides because 20 years ago, we were saying if there's not a cure for Alzheimer's, why is it important to diagnose this early? And now no one else is discussing this because there is general consensus that diagnosing dementia early, it really helps the experience and the journey of patients living with dementia. So we want to diagnose this early to start dementia-specific interventions. We want to diagnose early to help families with dementia-specific services, to discuss advanced directives and prepare for the future, to treat and identify early caregiver burnout that is super frequent. Of course, to include patients with Alzheimer's on clinical trials and on the new anti-amyloid drugs, to be sure that patients are safe at home and they are safe at driving. So usually when we are doing an interview on someone with a memory disorder, as per the screening test, we start with some cognitive screening test, and then we do a confirmatory test, and this is usually what we call a neuropsychology or neurocognitive assessment, and this is what we do in social memory net. And in the neurocognitive assessment, we check all these different cognitive domains. We check, we check for attention, executive function, language, visual spatial skills, and memory, of course. If we usually start with a MoCA, and if the MoCA is 12 or below, and if we know that the patient already has severe dementia, maybe we can focus that visit on identifying caregiver burnout, discussing management of non-cognitive symptoms in dementia, and doing all the interventions that we need to do. So if the MoCA is less than 12, we don't perform a full cognitive assessment due to the low values. So this is kind of the battery that we do in patients who speak English at Social Memory Net. Again, as I said before, if the MoCA is 12 or above, we do the brain learning test. This is a pure memory test where we read 5 times a list of 15 words and we see how much the patients remember. So we're really checking the learning ability and also the episodic memory. We also do the brain complex figure, which is copying a very complex figure, and then we check the visual memory by trying to see how much they remember from that figure, and we're going to see pictures of this. We do a denomination test, which is called the MINT. We do the language fluency with letters, and this is called phonological fluency, and with semantic fluency, and this is just as the patients to say words within a category. Usually we could use animals or vegetables in 1 minute. We do the trend making A and B, and these are 2 very good tests that don't depend a lot of language to check for visual spatial skills. In the case of the trend making A, more for attention. In the case of trend making B, we're really also checking executive function. We check attention by doing the digit spans, and we check visual spatial skills by doing the Benton line orientation. So this is the protocol in English. The question is, how can we adapt this to patients whose if Spanish is their initial language? This is just an example of a patient with the brain learning test. You see, as I said before, the 15 words in English. Each time we read the 15 words, we record how many words the patient remember. In this case, the patient is coming kind of a flat curve because he's not learning a lot. He's going from 6 to 6 to 6 to 7 and 7. And after 30 minutes, he could only remember 1. So in this example, this patient is really having learning problems and also episodic memory problems. This is a complex figure that I was referring before. We have a very particular way of scoring this test. It's kind of complex, and this test depends a lot of educational level too. And let's go through a case that I saw at Social Memory Net recently. So the first interview was in March 2024. We have a 70-year-old lady with memory complaints coming from Mexico. The memory problem started about a year ago. The daughter thinks that the symptoms were part of normal aging. The patient is not repetitive. She denies any episode of forgetting familiar persons, places, or things. She denies misplacing any objects. She doesn't need to use any memory aids. She's independent in all her activities of daily living, instrumental, except for finances. And this is interesting because her daughter pays the bills because the patient is not very computer savvy, but the patient reminds the daughter to pay the bills. So this is kind of reassuring. As I say, the patient is from Mexico. She speaks English. She never learned, she speaks Spanish. She never learned English. There is no family history of Alzheimer's and no history of head trauma either. So as for the social history, this is very interesting. The patient only attended 6 years of formal education in Mexico. So all the results of the memory test need to be put in perspective and interpreted in perspective in someone with low literacy level. She can read and write slowly. She used to be a stay-at-home mom, and she lives with her husband and a son and a daughter, no history of smoking, no history of alcohol, and she can walk 2 or 3 blocks. As I said before, as per the functional status, she is independent on the basics activities, and she's really independent on the instrumental activities. And in this case, since she never did finances, since she moved to USA, I think that she's independent, and the denominator on the instrumental, instead of being the number 8, is the number 7. So she's mainly not impaired. Medications, losartan, levothyroxine, and escitalopram. We did a screening test with a mini-COG that was 5 in 5, which is actually a normal result. And we do the Luria series, and I don't know if you are familiar with this. The Luria series, it's a very simple test for frontal dysfunction, and it doesn't depend on language. So I do this in every patient. So basically what you do a fist, a wedge, and palm. This 3 times, and then you ask the patient to repeat that. So it's a very good screening for frontal dysfunction in this case, and for executive function. In this case, the patient was able to do this normal. I did the semantic fluency in 1 minute, all this in Spanish, and it was 13 animals, which is a little low, but again, we need to remind of the educational level of this patient. And we did blood work that were basically normal. No thyroid disease, no B12 deficiency, nothing else. So this is the result of the Braille learning test in Spanish, okay? So you would see that it's different, and this is a validated Braille learning test, and the words are actually different from the one in English. So if you decide to do this test, you need to pull out from, there are 3 versions of the Braille learning test in different languages, so it's actually a good thing to download it with the original version. So in this case, we read 5 times the 15 words, and in the first trial, the patient learned 3, 4, 5, 6, and there was a good learning curve. And after 20 minutes, the patient actually remembered 7. So she learned 10 and she remembered 7, which is actually absolutely normal, okay? This patient had difficulties copying the right complex figure, and we thought that this could be related to the low educational level. And she actually had a MOCA of 19. Done in Spanish, and in the MOCA, she mainly missed the calculations, which depends a lot of educational level. So as a conclusion, when I saw this patient on the first time, I thought that most likely diagnosis could be normal changes due to aging versus very early mild cognitive impairment. And again, the caveats were that this patient had a low educational level, and her native language was Spanish. So just I put these slides of the new criteria from the Alzheimer's Association, and this is interesting because before this publication in 2024, we always were talking about normal cognition, mild cognitive impairment, and mild dementia. And now in the new versions, they really add this new category, which is here, the stage 2, which is not mild cognitive impairment, but it's not normal. And in this stage 2, we include patients who maybe have a slight decline in cognitive performance from baseline, but who have a normal cognitive status. But that really doesn't apply to our patient, because our patient clinically, she had no changes in cognitive status, okay? So this is the, this is the MOCA that I was referring before, and this is the version in Spanish. It has the same 3 animals, but the 5 words are definitely different. And she scored 26, which is actually normal. And this is the output of the memory test that we did. And we didn't do all the tests, but as I said before, we did the Braille learning test, and those results were absolutely normal. And she kind of struggled copying the complex figure and also remembering. But sometimes when you are addressing how much they remember from what they copy, if they really have difficulties copying, then maybe to see how much they remember is not very accurate, okay? So I saw her after 6 months when she came back with her MRI, which is down here. And I decided to repeat it, a new MOCA in Spanish, because there were like a 6 months gap between the first visit and the second visit. And the fact that in the second visit, her MOCA was again 27, before was 26. And the fact that she wasn't progressing is kind of reassuring and goes against any neurocognitive disease. I repeated the phonological fluency in 1 minute, and she gave 12 words compared to 13, so it's basically the same, and there were no new cognitive symptoms. As per the MRI, here we have a sagittal view. Let's see if I can play this. It was a video, but basically you will have to believe me because somehow I can't read this. But there is no hippocampal atrophy. There is very mild white matter disease. There is no cortical atrophy. And this is a sagittal tissue, no ventriculomegaly, and actually everything looks pretty normal. So based on this, yeah, now I can play it. Okay, that's good. I thought I couldn't play it. So this is the sagittal view, which is a very good view to have a global idea of atrophy. We usually start with the midline and we identify the corpus callosum, and then we identify the hippocampus on one side, on the other. And I'm going to stop it when I see the hippocampus. So we're going lateral, centrally. We keep on going. This is the lateral fissure. This is the temporal pole. Okay. And here we see the hippocampus on one side. So you could see that all the space of the hippocampus is filled in the hippocampus. There is virtually no space for the choroid fissure. So there's really no hippocampal atrophy. Okay. So as a conclusion, with a normal MRI, the fact that she had a normal MOCA, the fact that she wasn't progressing, the fact that the brain learning test was normal, and the only problem was really the copying of the complex figure, I understood that this was due to maybe low educational level, and I think that this patient doesn't have any true cognitive disorder. And we'll go to a second case. I don't know if we have any questions on the chat, Ted, or we'll keep on going.
We are good to keep on going. No questions in the chat, just some audio-visual technical difficulties that have been solved. So you keep going. Thank you.
Thank you. So we have a second patient, kind of similar. This is a 72-year-old robust lady from Peru. I saw her on the first visit in May 2024. At that time, she came with a main complaint of episodic memory loss that was very mild. But at that time, the patient was very stressed because she was the caregiver of her husband who had advanced Alzheimer's disease. And at that time, she was considering nursing home placement for the husband. She was independent in all her activities of daily living. She had history of depression and a little anxiety. She was taking escitalopram, and she had no family history of Alzheimer's disease. This is the social history. She had an educational level of 12 years. She was a former smoker, but quit many, many years ago. She was living with her daughter, and she had kind of a limited exercise capacity because when I saw her on the first visit, she was suffering from spinal stenosis, and she was having moderate to severe spinal pain almost every day. As per her functional assessment, she was totally independent. Past medical history, well-controlled diabetes, hypothyroidism. She was taking escitalopram and levothyroxine, and she had, as I said before, the spinal stenosis with severe pain. We did a screen test in Spanish. She had a normal minicog. She was oriented to time and place. She could do the Luria series okay. Her praxis were preserved. She had a semantic fluency of 24 animals in 1 minute. This is very, very reassuring. This is a very good result on this score. The ability to bring words within a category really depends on the medial temporal lobe. And when I see someone with such a high semantic fluency, I feel very reassuring that this doesn't look like Alzheimer's disease. And the labs were normal. This is her MOCA. So on the original MOCA, she only scored 24. This is the MOCA in Spanish, and you could see the 5 words in Spanish. So it's always interesting to see which cognitive domains were affected on the MOCA. And if you could see, her delay recall was low. She could only recall 1 of the 5 words, okay? So the cut point for someone with 12 years of education on the MOCA is 26 and above. So of course, I'm a little concerned that she lost 4 points here. Her MOCA is 24. Let's keep on doing some more tests and let's see what happens. That was kind of my thinking at that time. So this is the rate learning test. And you could see that there's a really nice learning curve with actually normal values in the 5 trial. And you could see here under 5. And then after 20 minutes on the A7, she remembered actually, it was very good recall. So it seems that when I did this test, her episodic memory was fine. And sometimes you find this, that on the MOCA, the patients only remember 1 of the 5 words, but on the rate learning test, which is actually a much harder test because you're remembering and learning 5 words, 15 words, sometimes they actually do better. And that kind of cognitive fluctuation through the visit sometimes give you cues of what's really going on with the patient. So this is a complex figure. This is what we asked the patient to copy. This is what she did, which was actually excellent. Immediately after they copy this and we timed the test it takes to copy this, we asked them to see how much they remember, and she actually remembered very good. And then this is 20 minutes, what she remembered after 20 minutes, that was actually very good. I did the trials in her, the trial making A without mistakes, and she did it in 30 seconds. This is very quick and normal. And the trial making B without any mistakes, again, for visual, spatial, and executive function, no mistakes. So the trials were really good. This is her MRI, and this is the sagittal view. Overall, there is really very mild cortical atrophy. The sarca are kind of symmetric, so we identified the corpus callosum, we identified the lateral ventricles, the thalamus, the cingulate sarcas, and since the sarca are even and symmetric, and not a lot to say here. This is the T2 flare. She doesn't have ventriculomegaly. She doesn't have white matter disease. It looks like a very healthy brain. And this is the coronal. And here we see the hippocampus and the para-hippocampus gyrus. Again, not a lot of atrophy. Looks like a pretty healthy brain. So this is kind of the output from the full cognitive assessment that we went through that. We discussed the MOCA a little low. And the way you interpret this is you see any values below 5% means really abnormal and below 2 standard deviation from the median. So if you see the results, actually she did very well in almost everything except for the digit span, which is a true attention test. But there is not very consistent because she did very well on the trial making A that also depends on attention and working memory, but she didn't do so well that day on the digit span. And this is the output. Anything that reaches the outer circle means 2 standard deviation from the median. And as you can see, really, this is kind of a normal test. Good. So what happened? I saw her again after 6 months. She was doing much better. She had spinal surgery with decreased pain. She was taking much less opioids. Unfortunately, her husband passed away, but her mood was slowly improving because she had much less caregiver stress. She was more focused. She had no memory complaints, no mistakes. And I decided to repeat the MOCA in Spanish. And on the same MOCA, now she scored 28, which is basically normal. So as a conclusion from this patient, I think that what happened is when I saw her on the first visit, she was having anxiety, depression, and caregiver stress. And as things kind of solved down with time, she kind of resolved her cognitive issues. So again, my diagnosis here will be normal cognitive changes due to aging in the context of pain with the spinal stenosis and in the context of depressive symptoms and caregiver burnout. So I just wanted to show you 2 cases. We see many cases who are Spanish speaking. We try to start with the MOCA and we do as many tests as we can, because really when the patients have normal change due to aging versus early MCI versus mild dementia, you need to take your time and understand the full battery to make the most accurate diagnosis. And that's what I was trying to show you. We are lucky because we have a social worker who at Social Memory here in Atlanta, who is originally from Colombia. So between her and me, we can really do the full battery in Spanish. So I'm open to questions and any comments from the audience. And thank you so much for attending.
Hey, thanks so much, Dr. Cohen. That was awesome. Great presentation. You do have one question in the chat, if you can see it. It's from Dr. Maddie,
Okay.
who originally found herself writing as Emma Matuva, but it was actually Dr. Maddie. So her question is right there.
I cannot see. Let me just.
So let me go ahead and read it out loud just in case folks are looking at it. We're wondering if you have any data or experience with patients who are native Spanish speakers, but are bilingual. They learned English in elementary school or high school and lived in the US for decades.
That's a great question. So some domains on the full cognitive assessment really depend on your native language, especially. So there are two tests that I think are much better to be tested in native language. One is the MINT. So the MINT is that test where we really want to pick up denomination problems. So we show 32 pictures of objects. And the first ones are really easy, like butterfly, coffee, but the last pictures are really hard. And remember that here in memory disorders, we're not checking for their knowledge, but we are checking for change in their knowledge. So if someone really never learned to nominate those very complex words, then they won't remember. So I think that the MINT should be taken ideally in the native language. But the rest, for example, the trails don't depend a lot of language, so definitely could be taken in English. The Ray learning test, the words are pretty common. If the patient understands the 15 words, I think it could be taken in English. But the fluency test, anything that depends on language, I think is, if you really want to understand the result better, I think we should be taking the fluency test and the denomination test in their native language.
Thanks so much for that. I need to rethink something, and that was when you were talking about the Ray complex figure reproduction and reconstruction with time passing, that you talked about that being an educationally sensitive
Depends
tool.
on education, because in order to copy that complex figure, most people will have a strategy and will start with a big square and then put the other parts. If you never learn geometry, for example, this lady, she only attended 6 years of formal education. She didn't know what a triangle, what a pentagon is. That's why I think that one depends on education more than other tests. But I don't have evidence for that. This is just what I see in clinical practice.
Hey, thanks so much. Hey, Dr. Loring, I know that you're on. I don't know if you can come off mute. It's sort of same question. I just need to rethink the Ray complex figure and your thoughts on this being an educationally vulnerable assessment. And he may not be able to come off mute. I guess the other thought that I had is you presented some cases where patients finished their evaluation and got some great news, meaning that their concerns or other people's concerns about memory loss were not really substantiated. You talked about that last case being related to kind of some anxiety and depression related to what was going on. And so how often do you get to deliver great news when you're doing memory assessment tests, whether in Spanish or in English?
That's a great question. So it really depends on the population that you're dealing with. For example, when I was working in Buenos Aires, that was a very well-educated population with a lot of aware of symptoms. So probably normal changes due to aging was the most common diagnosis that I was providing. Now that I work in a Grady, we see many cases who presented with late diagnosis, severe dementia. So in the Grady clinic, it's not so often. I would say that probably mild dementia is the most common diagnosis that I make. And the second one would be moderate dementia, and the third one would be mild cognitive impairment, and the fourth would be normal changes due to aging. So unfortunately, I don't provide those great diagnoses very often, but in any memory clinic, what we want to do is diagnose this very, very early. So it could be okay to send patients who had a complaint and who actually has everything normal and be able to say, hey, I don't think you have a neurodegenerative disease. I think this is just whatever is going on.
Great. Hey, thanks so much. Could you go ahead and show the QR code and go ahead and put that on full screen? And then Dr. Maddie has a follow-up question. And her follow-up question is, any further thoughts about bilingual patients? Is decline in cognition faster or more pronounced in the secondary language compared to their mother language?
That's a great question. I don't have a good answer for that. That's interesting. One time I saw a patient who was bilingual and he actually forgot the first language and he could only speak the second language, but I don't know if that's a good example.
I do have a colleague who took his father back to a home country to figure out if he was as functionally impaired and cognitively impaired in his native tongue versus the other, and he found out it was the same for both. So not very anecdotal, so not too sure about that.
Yeah, this is anecdotal.
Okay.
Nice.
Let's see, I'm checking the chat one more time. Welcome to the new year and all sorts of new downloads to Zoom, because a lot of people had problems with microphones and screens and sound. And so I'm glad that we made it through that. Thanks again, Dr. Cohen, for just a great presentation today. Look forward to seeing you at our next GM Insights next month. Thanks again.
Thanks so much for attending. Thank you. Bye-bye.